Welcome to the Deep Dive, the show built to distill critical, dense research into clear, actionable knowledge. Today, we are taking a massive amount of technical biomechanical data and turning it into, really, a personalized roadmap for millions of people. We are diving deep into knee osteoarthritis, or KOA, a debilitating condition that is arguably the most common musculoskeletal disorder globally.
It's a crisis we really need to face head-on. KOA is a leading cause of long-term physical disability, and it limits mobility and quality of life for massive segments of the population. And the numbers they're only going up.
Up dramatically from what I've seen.
Oh, yes. If you look at the projections, they're fueled by an aging demographic and, of course, the growth in the obesity epidemic. So the prevalence of symptomatic knee OA is just expected to rise dramatically over the next few decades. And current treatment, it often defaults to surgery or medication, but our focus today is entirely different.
Exactly. Our mission is centered on non-surgical, non-pharmacological treatments, and we're looking at the specific and most common form of the disease, medial tibiofemoral KOA.
Which is the arthritis on the inner side of the knee.
Right. And we are specifically looking at how we can physically manipulate two elements, what you put in your shoe and how you move your feet, to fundamentally change the structural forces acting on that joint.
And if we're going to talk about changing forces, we have to start with the single most important mechanical concept in all of knee OA research. That's the external knee adduction moment, usually just called CAM or CAM.
Okay, Cam.
If you can grasp the CAM, you really grasp the mechanics of KOA progression.
I understand the term is central, but let's make sure we ground this complex physics concept for everyone listening. What exactly is the knee adduction moment, and why is it so dangerous?
Okay, think of your knee as a hinge. And now think of your body's weight,
Mhm.
or more accurately, the ground reaction force, as someone trying to push that hinge closed from the side.
Ah, okay.
The CAM is a measure of that rotational force, the torque, that tries to push the knee into a bow-legged position, or adduction, during the stance phase of walking.
So it's not just the weight bearing down on the knee, it's the leverage of that weight.
Precisely. It's all about the lever arm. If you're carrying a heavy grocery bag, it's much easier to hold it close to your body than if you extend your arm straight out.
Of course.
The further away that line of force is from the center of the joint, the longer the lever arm and the greater the moment, or the stress. During walking, the ground reaction force naturally passes medial to the knee center, to the inside. And that creates a lever arm that concentrates all this pressure on the inner side of the joint.
And that concentration of pressure, that's the grinding that causes the cartilage wear and tear.
Yes, that's exactly it. The PM is the gold standard. It's a surrogate measure for evaluating that joint load. It is strongly, very strongly, correlated with the medial compartment contact force, that destructive grinding pressure.
So the higher the peak KM during walking, the faster your disease is likely to progress.
That's the connection. And the research connecting high CAM to disease progression it's terrifyingly precise.
How precise are we talking?
It is. This is why the focus is so intense on this one variable. Studies show that an increased KM is a massive predictor of disease severity. In fact, for every 1% body weight multiplied by height increase in the peak KM,
Okay.
the risk of OA progression increases by a factor of 6.5.
6.5 times. That's an incredible correlation.
It is. It's so high, it essentially makes the CAM the primary target of any non-surgical intervention. If we can physically shorten that lever arm and decrease the CAM, we are not just managing pain. We are fundamentally slowing the mechanical destruction of the joint itself.
So that is the entire paradigm shift we're talking about today. We're looking for personalized mechanical blueprints to unload the joint, moving away from painkillers that only mask symptoms.
Right, and those painkillers can have debilitating long-term consequences, damage to the liver, kidneys, or the gastrointestinal tract with chronic use. We're talking about changing the structural physics of how you walk.
That sets the stage perfectly for Section 1, orthotic intervention. We're starting where the body meets the ground with insoles and exploring the surprising combination of the lateral wedge and arch support.
So the standard biomechanical approach for medial KOA patients has, for a long time, been the use of a simple lateral wedge insole.
And just to clarify, that's an insert that's thicker on the outer edge, right?
Exactly. It's thicker on the outside, and it forces the foot to shift its weight slightly laterally, or to the outside. The goal is simple. Shift the center of pressure away from that overloaded inner compartment of the knee to the outer compartment, and by doing so, reducing that harmful KEM.
But the research we have today zeroes in on a patient subgroup that really complicates this simple approach. We're talking about individuals who have medial KOA and also have concomitant pronated feet,
Or flat feet, as most people would call it.
flat feet. And why is this subgroup so important?
Because a pronated foot, a foot that rolls inward or flattens excessively, introduces these complex dynamics that a simple wedge might actually, well, it might make things worse.
How?
When a wedge pushes the foot laterally, a flat foot might lack the intrinsic stability to resist collapsing further. This can lead to instability or, pain somewhere else, like the ankle or even the hip. The pronated foot posture is associated with unique and often poor clinical and biomechanical outcomes in this population.
So, a recent, very rigorous, randomized crossover trial decided to directly address this limitation. They compared two specific interventions in this flat-footed KOA subgroup.
That's right. They compared the standard approach, a 5-degree lateral wedge insole alone, which we can call LW, against a composite approach. That was the same 5-degree lateral wedge insole with the addition of custom arch support. Let's call that LW plus CAS.
And a randomized crossover study is a really powerful design.
Oh, it's excellent because it uses participants as their own control. You're not comparing one group of people to another. You're comparing one person's reaction to two different things.
So can you walk us through the setup? How did they do it?
They recruited 26 participants, and 22 of them completed the full protocol. Each participant wore one intervention, so either the LW or the LW plus CAS, for a full 2-month period. And crucially, they included a 2-month washout period in between.
A washout period?
Yes, where the patients wore no insoles at all. This ensures that any residual effects from the first intervention didn't carry over and, contaminate the results of the second. This design allowed them to directly compare how the same exact knee responded to the two different mechanical supports.
And they measured the outcomes using standardized clinical metrics. It wasn't just, hey, did your knee hurt less?
Exactly. They used the gold standard tools. For the knee itself, they used the Western Ontario and McMaster University's Osteoarthritis Index. Everyone just calls it the WOM.
Yeah, got it.
It provides scores for knee pain and for physical function. Then for the foot, they use the revised short-form foot function index, or FFIR, which measures foot pain and stiffness. And maybe most objectively, they use the timed stair climb test, a functional measure of real-world ability.
Okay, so what happened when they compared the two? Did adding custom arch support really make a measurable difference beyond that basic lateral shift?
It was a clear-cut case of superiority for the combined insole, the LW plus CAS. Let's look at the objective finding first. The timed stair climb. Significant treatment effects were observed for the timed stair climb, and the greatest improvements were seen when patients wore the LW plus CAS.
So that's tangible evidence they were physically moving upstairs faster and more easily with the combined insole.
Yes, that objective functional gain is critical, but the pattern held true subjectively as well.
In the pain and function scores.
In the pain and function scores. Within conditions, significant improvements for WOMAC pain and physical function, as well as the FFIR pain and stiffness, were observed only when participants were using the LW plus CAS.
Only with the combined one.
Only. The plain lateral wedge in this specific subgroup of flat-footed patients, it just didn't achieve statistically significant improvements across those internal pain and function metrics.
Let's translate that into something truly relatable, pain relief intensity. Can we actually quantify the difference the arch support made?
We can. The study provided quantifiable symptom relief data. They found that participants experienced a significant 30% improvement in their WOM gain intensity score while using the combined insole.
30%, that's a big number.
It is. Now, compare that to the standard lateral wedge alone, which only offered about a 12% improvement.
Wow, so that's more than double the pain relief. If a patient is considering a mechanical intervention, that 18% difference is massive, and it just underscores the need for personalized care, especially recognizing concurrent foot issues.
Absolutely. And the patient preference data backs this up, which is perhaps the most real-world outcome of all. More participants reported adverse effects when wearing the lateral wedges alone, things like new foot or ankle discomfort.
Which makes sense if you're forcing an already unstable foot into a weird position.
Exactly. And conversely, the vast majority of participants expressed an overall preference for the LW plus CAS.
So this suggests that for a patient who already has a pronated or unstable foot, the standard lateral wedge might be creating a new problem while solving the old one, but the custom arch support acts as the necessary stabilizer.
Precisely. The clinical conclusion is that these preliminary findings strongly suggest that adding custom arch support to a standard lateral wedge insole vastly improves both foot and knee symptoms, specifically in the subgroup of people with KOA and pronated feet.
Okay, so to understand the mechanism behind this preference in pain relief, we need to look at the immediate biomechanical effects, not just the 2-month clinical outcome. How did the arch support change the actual way the foot and knee interacted, like right away?
A separate study examined these immediate biomechanical changes on gait. First, and this is important, both insoles achieved the primary goal. Both the LW and the LW plus CAS reduced the knee adduction moment impulse compared to walking without orthotics.
So they both work to offload the knee.
They both work. The LW alone gave about an 8% reduction, and the LW plus CAS gave a 6% reduction, so both were effective.
That's interesting. So the plain wedge reduced the CAM slightly more, 8% versus 6%, but the LW plus CAS was clinically superior. Why is that?
Because the goal isn't just CAM reduction at all costs. The goal is comfortable, functional, and sustainable CAM reduction that doesn't cause pain somewhere else. And the key distinction was in the foot's frontal plane mechanics, basically. How much the foot rolled side to side during the stance phase.
Okay, let's elaborate on that difference. You mentioned upversion earlier.
Right. So when a foot is flat, it naturally rolls inward or pronates. When you add a lateral wedge, it forces the foot outward into eversion. What they found was the plain lateral wedge alone resulted in a significantly more everted or outward rolled foot position. It was measured at 4.3 degrees.
And that's too much.
That excessive eversion is what likely stressed the ligaments and tendons of the ankle and foot, causing those adverse effects the patients were reporting.
And the arch support solved that instability.
It did. The LW plus CAS stabilized the foot. It resulted in a less everted position, measured at 3.2 degrees, and critically, it reduced the foot's frontal plane excursion compared to the other conditions.
Which means the foot wasn't allowed to wobble or roll as much?
Exactly. It wasn't wobbling during that vital stance phase. The arch support provided the necessary medial stability to balance the lateral force of the wedge.
So the combined orthotic is subjectively preferred because it's reducing the load across the knee while effectively minimizing the risk of causing new foot and ankle symptoms. It's the perfect biomechanical compromise.
That's the clinical significance. It's not enough to simply shift the load. You have to shift the load stably. The LW plus CAS achieves that balance for the patient with a pronated foot.
This all hinges on the term custom arch support, which brings us to the very practical financial reality. The cost and logistics of custom orthotics versus over-the-counter alternative.
And it's a huge barrier for many patients. We have to acknowledge that. High-quality, ready-made, or over-the-counter OTC orthotics do exist. Many are clinically proven to offer good shock absorption, relieve pain, and provide a degree of biomechanical correction for general issues like overpronation.
So it's not an all-or-nothing situation.
Not at all. But when we talk about customized insoles for a complex structural issue like KOA combined with pronation, the price tag skyrockets.
It does. So why is that? If the material cost is relatively low, where is all that money going?
Well, according to estimates, the raw manufacturing cost for the actual orthotic shell, the plastic and foam, is often $100 or less. The high overall cost, which can easily reach $500, $800, sometimes more, stems entirely from the comprehensive professional process required to ensure precision and personalization.
So you're paying for the blueprint, not just the building materials.
Exactly. It starts with a thorough examination by a specialized clinician, a podiatrist or an orthopedist. They need to assess the entire biomechanical chain: the legs, knee, ankle, foot, your overall gait pattern. They might use specialized gait analysis equipment, maybe even x-rays, to rule out other issues or precisely map the alignment. This is a labor-intensive professional service.
And the casting process itself needs to be incredibly precise.
It must be perfect. For a truly custom orthotic designed to correct alignment like adding arch support to a lateral wedge, the casting process must be done in a non-weight-bearing position.
And that's the crucial difference.
It's everything. The clinician makes an exact impression of your foot when it's in its ideal non-loaded shape. They often use wet plaster strips or a specialized foam box that you step into, what they call a stomp box. If they just tell you to stand on a piece of foam, you're just getting a mold of your deformed foot shape, not the corrected shape you need.
So the patient is paying for the guarantee that the device perfectly matches their foot's ideal biomechanical shape. And that's essential for correcting the pronation while supporting the lateral wedge shift.
It's the guarantee of precision. In KOA management, where a few millimeters of misalignment can increase your risk of progression by 6.5 times, precision is, well, it's worth the investment. particularly when OTC solutions fail or cause secondary pain. The cost covers the expertise, the time, the specialized materials, and the commitment to getting that personalized blueprint exactly right.
That's a very helpful distinction between the shell cost and the knowledge cost.
Mm.
Moving into section 2, we're going to transition from passive support, the orthotic, to active intervention, which is changing how you actually move. This is active gait modification, and it's arguably one of the most exciting avenues for unloading the knee.
Gait modification is so powerful because it uses the patient's own body mechanics as the therapeutic tool, often with an immediate effect. And we'll look first at manipulating the step width. We're talking about simply consciously taking a wider step.
It seems a little counterintuitive. We often think of walking with a very narrow straight path as being efficient. So how does widening the step physically reduce that massive rotational force of the knee adduction moment?
Let's go back to our lever arm analogy. When you walk, the ground reaction force comes up from the ground, passing medial or inside the knee joint center. That distance between the force line and the joint center is the lever arm. If you take a wider step, you physically move the knee joint center closer to the foot center of pressure.
You are shortening the distance between the hinge and the push.
Precisely. By shortening that external lever arm, the peak knee adduction moment, the PKM, is drastically and immediately reduced. It's pure applied physics in motion.
This sounds simple in theory, but measuring this effect dynamically across different step widths, that must require a highly specialized system.
It does. One study used a very innovative method, a robotic elliptical stepping system. This system allowed researchers to dynamically vary the footplate positions between narrow, neutral, and wide step widths while measuring all the forces and moments in real time.
So it provided a continuous objective assessment of the impact of step width on the knee.
Yes. And the major findings from this high-tech stepping study were, well, the hypothesis was confirmed overwhelmingly. A wider step width, which they call WDSW, consistently and significantly produced a lower PKM compared to both neutral and narrow step widths. And that was true in both the KOA patients and the healthy control subjects.
And the KOA patients themselves, did they see a significant reduction?
They did. When comparing the wide step width to the narrow step width, the KOA group saw a specific reduction of 14.35% in their peak knee adduction moment.
14% is a big deal.
It's a clinically huge gain. The control group saw an even larger drop, 23.42%, which tells us that the KOA disease state inherently makes the joint harder to unload. But that 14% reduction is still a massive win. Imagine achieving a 14% reduction in joint load just by changing where your feet land.
Now here's the critical check for any gait modification: the safety implications. When you force the body to change its preferred pattern, you risk shifting the mechanical burden somewhere else. We worry about load shifting to the kneecap or the hip.
That is the most crucial takeaway from this research. And the investigators specifically checked for this transference of load. They monitored the peak knee flexion moment, PKFM, and the peak knee internal rotation moment, PKRM.
And what did they find?
They found that these other major knee moments remained essentially unchanged with the wider step width.
So no negative side effects.
Exactly. This is enormously positive news for KOA rehabilitation. The modification successfully targets the harmful adduction moment without increasing the overall joint load in other vulnerable directions. It's not stressing the patellofemoral joint or causing abnormal hip rotation. It's a clean biomechanical intervention.
So we've established that a wider step works, but how do clinicians move beyond prescribing vague instructions like just walk wider and get to true personalized dosing? This is where the slope analysis becomes vital.
This is the future of individualized therapy. The researchers observed a strongly linear relationship between step width and PKM, a negative slope. As step width increases, moving right on the graph, PKM decreases, moving down. And they realized this linear slope is subject-specific.
So instead of testing dozens of discrete positions, you just measure that individual's unique slope, and you have a roadmap for how much change equals how much benefit.
Exactly. This personalized slope allows for real-time, subject-specific modification to minimize PKM. It eliminates the need to test multiple arbitrary step widths. But what was really fascinating was the difference in the slope magnitude between the groups.
Tell us about that difference in sensitivity. How did the groups compare?
The KOA patients showed a significantly steeper or higher slope compared to the healthy controls.
What does that mean in practical terms?
It means that for every millimeter that a KOA patient widened their step, they achieved a dramatically greater reduction in PKM compared to a healthy individual making the exact same adjustment.
That implies that KOA patients, due to their existing pathological mechanics, are much more sensitive to the therapeutic leverage of this modification. Their bodies are primed to benefit significantly from a seemingly minor change in gait.
It makes this approach incredibly potent for the therapeutic setting. And furthermore, the study went a step further by looking at what physical factors predicted lower PKM. They used regression analysis and found that medial tibia inclination, so the angle of the lower leg bone, was the strongest predictor associated with a large decrease in PKM.
What else predicted the mechanical response? Were there other factors?
Yes, also important were foot plate lateral reaction force, which is basically how much force the foot generates sideways, the foot plate reaction, inversion torque, and stepping speed. These factors, once they're integrated into clinical tools, could eventually inform precise real-time adjustments or prediction models. We're moving closer to a fully algorithmic gait prescription.
So if step-width modification is one powerful tool, adjusting the foot progression angle, or FPA, that's the degree to which your feet toe in or toe out is another. And this has yielded perhaps the most dramatic long-term results we've seen.
FPA adjustment has moved past immediate biomechanical effect and into actual disease modification. A groundbreaking year-long randomized trial looked at patients with mild to moderate KOA and personalized the intervention completely. They didn't just prescribe a universal angle.
So how did that personalization work in practice?
For each patient, physical therapists tested them, seeing whether an inward angle, toe in, or an outward angle, toe out, for either 5 or 10 degrees, reduced their knee load, their KMM, the most. Then they trained the patients to walk consistently with that specific personalized angle over the course of an entire year.
That requires significant compliance and commitment from the patient, but the clinical outcomes must have been worth it.
They were dramatic. Those who successfully maintained the prescribed foot angle showed pain relief that was equivalent to highly effective over-the-counter pain medications.
Equivalent to medication.
Yes. Specifically, they saw a significant 2.5-point reduction on a 10-point pain scale. To put that in perspective, the control group, who just maintained their normal gait, only saw a little over a 1-point reduction.
That's a measurable, massive functional advantage over just maintaining a baseline gait. But
Yeah.
the benefit extended far beyond just pain relief, right?
Yes, and this is the most compelling finding of all. The adjusted gait pattern resulted in slower cartilage degeneration in the inner part of the knee over that entire year.
So it's not just masking pain, it's slowing the actual disease.
Exactly. Cartilage degeneration was measured through advanced magnetic resonance imaging MRI scans. This trial provided compelling, evidence-based data that a personalized biomechanical intervention can actually slow the physical progression of the disease.
This fundamentally changes the conversation about treatment options. We have long relied on pharmaceuticals to manage pain, but they don't stop the underlying degradation. This intervention does both.
This is the massive advantage. Pharmaceuticals, like long-term nonsteroidal anti-inflammatory drugs or NSAIDs, carry risks. Chronic use can lead to liver or kidney damage or stomach ulcers. Gait modification is not invasive. It avoids those systemic risks and offers comparable or superior pain relief while also addressing the foundational mechanical issue, the excessive load. And that translates directly into slower structural degradation. It is truly mechanical medicine.
It essentially turns the act of walking into a therapeutic exercise rather than a degenerative activity.
Precisely. By optimizing the physics of the gait for that individual, you convert a daily necessary activity from a destructive force into a corrective, or at least a maintenance force.
That brings us logically to Section 3, where we have to address underlying structural issues that inherently increase KOA risk, specifically genu varum, which is commonly known as bow legs.
Right, genu varum. It's characterized by an outward curvature of the legs, and it creates that distinct gap between the knees when you're standing with your feet together. Structurally, this alignment is a nightmare for the medial knee compartment because it dramatically and constantly increases the external knee adduction moment. The body is always slightly leveraged against itself.
So if a patient has bow legs, is that alignment fixed forever, or can physical therapy intervene?
Well, that depends on the root cause, and it's a critical distinction to make. If the deformity is fixed, meaning it's caused by the shape and positioning of the bones themselves, then non-surgical approaches are limited. They're about symptom management and stability enhancement. Only surgery can truly correct the axis.
But there is another possibility.
Yes. However, if the condition stems primarily from tight hip muscles, muscular imbalances, or soft tissue shortening, then targeted exercise and stretching can significantly improve leg rotation and overall functional alignment.
But regardless of whether it's fixed or muscular, the mechanical stress is the same, and it's devastating to the joint.
Absolutely. Genivarum places predictable and excessive stress across the joint. The inner compartment experiences chronic compression, leading to accelerated wear of the medial meniscus and the joint cartilage. That is why it is so strongly associated with medial joint arthritis.
And what happens on the outer side of the knee in that scenario?
The outward curvature creates a gapping on the lateral or outer aspect of the knee. This puts chronic abnormal tensile stress on the lateral collateral ligaments, which are essential stabilizers of the knee. This misalignment also contributes to a whole host of secondary issues. Increased risk of patellofemoral pain, syndrome pain behind the kneecap, as well as Achilles tendonitis, meniscal tears, and generalized poor balance, especially when trying to move sideways.
So if we can't change the bone structure through exercise, the goal of the exercise must shift. It's about damage control and stability.
Correct. The goal is stabilization. It's strengthening the muscles that support and guide the knee, managing weight to reduce the overall load, and potentially reducing the knee spacing if the cause is muscular tension and poor control. We're trying to build a muscular scaffolding around the inherent structural flaw.
Since load is the enemy, the absolute priority must be low-impact activities. What types of exercises are safest for someone with existing KOA or genu varum?
Anything that minimizes ground reaction force and rapid deceleration. So recommended activities include swimming, which is non-weight bearing, cycling, rowing, using an elliptical machine, and flexibility-focused practices like yoga, Pilates, and Tai Chi. These all maintain cardiovascular fitness and muscle strength without the violent forces and impact.
And on the flip side, what are the classic high-impact activities that must be avoided, as they would just magnify that damaging stress?
High-impact activity should really be minimized or eliminated entirely. That means running, jogging, high-intensity aerobics, and any sports that involve jumping, cutting, or rapid stops. Think basketball, soccer, volleyball, or tennis. Every single ground strike in those activities sends a shockwave up the leg that concentrates right on that vulnerable medial compartment.
Beyond general conditioning, we need to focus on targeted strengthening exercises to build that critical muscular scaffolding around the knee and hip.
The foundational strength starts with the primary movers of the knee, the quadriceps and the hamstrings. We need to focus on controlled loading. Quadriceps strengthening, often through controlled leg extensions or squats to a limited depth, ensures the kneecap tracks properly and the joint is stable. And equally important is hamstring strengthening, maybe through leg curls or glute bridges, which provides the necessary counterbalance to the quads, ensuring dynamic stability.
But for Jenny Vorum, the real game changer is often addressing the hip, since that's what dictates the line of pull for the entire leg.
Absolutely vital. Weakness in the hip, specifically the adductors, your inner thigh, and abductors, your outer thigh, allows the knee to fall into these dysfunctional positions. So we need dedicated hip strengthening, maybe using resistance bands for abduction, pushing the leg out, and adduction squeezing the leg in. This strengthens the guiding muscles that keep the knee tracking correctly. And we can't forget core strengthening, things like planks and bridges, which ensures the body's trunk is stable, providing a firm foundation for the legs to move from.
Now let's talk flexibility, which is crucial if we suspect tight muscles are contributing to the alignment issue.
We need to focus on stretches that specifically target the muscles influencing leg rotation. A great one is the internal hip rotation stretch. You stand, lift one foot, and gently rotate the foot inward and outward, going as far as is comfortable and holding that rotation for 20 to 30 seconds. This is designed to gently increase the flexibility and range of motion in the hip capsule, which can, in turn, help reduce the outward appearance of the bow leg.
And addressing the gluteal muscles is key too, right? Tightness there can also yank the leg out of alignment.
That's where the sitting stretch or the figure 4 stretch comes in. By sitting and placing your ankle on the opposite knee, you create a deep stretch in the piriformis and other gluteal muscles. Relaxing and lengthening these external rotators helps relieve the tension that might be contributing to the knee being guided outwards.
Finally, are there any specific alignment-focused movements that consciously try to train the muscles to pull the knees inward?
There are two excellent examples mentioned in the sources. One is the foam roller toe touch. You take a foam roller, or even just a rolled up towel, and you squeeze it firmly between your knees while performing a toe touch or bending forward. This activates and strengthens the inner thigh muscles, the adductors, that are instrumental in actively pulling the knees inward.
So you are basically training the body to contract those neglected muscles?
Yes. And the second is the toes in squat. You intentionally rotate your feet inward until your big toes are touching. When you perform a shallow squat in this position, It strongly emphasizes the inner thigh muscles over the outer thigh muscles. You are effectively retraining the muscular firing pattern to support a more neutral alignment.
Given the noted association between genu varum and impaired balance, especially during lateral movements, balance training has to be a key element of the therapy.
It is absolutely essential for proprioception and for safety. Recommended balance training includes fundamental exercises like single leg standing and tandem standing, placing one foot directly in front of the other, heel to toe to enhance static balance. More advanced patients can use instability devices like a BOSU ball or a balance board to improve dynamic stability, making them more resilient during walking and reducing the risk of falls or aberrant gait patterns.
We've covered the devices and the movement patterns, but this entire discussion really hinges on personalized treatment. That brings us to section 4. Personalized prediction. We need to know who will benefit the most from these expensive, time-consuming interventions.
This is a crucial step in clinical translation. Lateral wedge insoles, whether they're combined with arch support or used alone, they do not work universally. Clinicians can't afford to just prescribe them blindly. So researchers sought to identify clinically accessible variables, things you can measure without a fancy lab, that predict a successful reduction in the knee adduction moment impulse. They define that reduction as a positive biomechanical response.
And the core challenge here was showing that low-tech, low-cost assessments could be just as effective as expensive, high-tech lab analysis in predicting success.
Exactly. They compared two classes of tools. On one side, you have the resource-intensive laboratory-derived data, 3D motion capture, force platforms, sophisticated gait analysis, the works. And on the other side, the clinically accessible measures. Simple tools that any therapist or physician could use right there in their office.
What were some of those accessible measures that offered predictive power?
They used a wide battery of simple instruments. We're talking about numerical rating scales for patient pain, the Foot Posture Index or FPI, using a simple goniometer for joint range of motion. They even leveraged a smartphone's internal inclinometry to measure tibial angle.
A smartphone.
Smartphone. And they measured gait speed using simple timing gaits and assessed foot progression angle by asking patients to walk across paper using wet sock prints.
It's the ultimate David versus Goliath comparison. Did the simple model hold up to the sophisticated lab data?
It held up beautifully. The predictive ability of the clinically accessible models performed almost identically to the resource-intensive laboratory-derived models. They achieved similar area under the curve, or AUC, values on the receiver operating characteristic curve.
That is immensely encouraging for the future of KOA management. It removes the necessity of having a $200,000 lab setup just to determine if a patient is a good candidate for orthotic intervention.
It means we can transition toward truly personalized treatment plans using tools that are affordable and readily available in any clinic. It allows us to triage patients much more effectively. Now, let's drill down into the profile of the ideal responder, the specific variables that most frequently and significantly predicted a positive K reduction.
What emerged as the strongest and most frequent predictor variable across different types of insoles and different response thresholds?
Faster walking speed was the MVP. It emerged most frequently and consistently as a significant predictor variable. Essentially, a greater likelihood of achieving a significant K impulse reduction was strongly associated with a faster baseline walking speed.
Why might walking speed be such a powerful predictor? If a patient is walking faster, doesn't that inherently increase all the forces?
It does increase the raw forces, but a faster walking speed likely indicates a better baseline level of fitness, maybe less severe baseline disease, or just better overall motor control. Patients who are more functionally robust might be better able to integrate and adapt to the mechanical manipulation introduced by the orthotic. Slower speed often indicates more severe pain and avoidance behaviors, which might make them less responsive to a forced mechanical change.
That makes a lot of clinical sense. What was the second major predictor variable?
Lower FFI pain, which means a lower baseline score on the foot pain subscale of the Foot Function Index, also significantly predicted greater odds of being a biomechanical responder.
And this ties back into our earlier discussion about the pronated foot.
It does. If the patient's foot is already painful, the introduction of a lateral wedge, even with arch support, might be mechanically resisted or rejected by the patient's protective muscle guarding. That reduces the orthotic's effectiveness. If the foot is relatively pain-free, it's a more pliable platform for intervention.
We also noted a demographic factor that was predictive, particularly for the combined orthotic.
Yes, specifically for the lateral wedge with arch support condition, the LW plus CAS, female sex was a significant predictor of a positive biomechanical response. Female patients were statistically more likely to see the benefits of the combined orthotic.
That's fascinating. It suggests a gender difference in how the foot structure and gait mechanics respond to the added stability of the arch support. This is vital information when prescribing this particular combination.
And finally, a few variables showed promise, though they didn't quite hit that statistical significance threshold of p0.05. These near-significant variables included having less varus alignment, so they were less bow-legged to begin with, lower radiographic severity, a lower Kellgren and Lawrence grade of existing damage, and interestingly, a slightly higher baseline numerical rating scale pain score.
So, if a clinician is looking for the ideal candidate for orthotic intervention, they're looking for a patient who is female, walks at a relatively faster pace, has relatively low foot pain, and perhaps has a lower overall severity of existing disease. That provides a clear, evidence-based pathway for triage.
It moves the prescription of orthotics from a trial-and-error process to a predictive, evidence-based prescription. It maximizes the odds of success and ensures resources are allocated effectively.
We've covered an incredible range of data today, moving from the foundational biomechanics of the knee adduction moment to the nuanced world of custom orthotics, personalized gait modification, and now predictive modeling. Let's synthesize these key takeaways.
The central overriding theme is that managing medial knee osteoarthritis is fundamentally shifting from purely medical management toward personalized mechanical manipulation.
Yeah.
We are treating the physics, not just the pain.
When it comes to orthotics, the research gave us what we could call the pronated foot rule.
Yes. The major rule is that a standard lateral wedge is suboptimal for KOA patients with flat feet. The combination of lateral wedges and custom arch support is essential because it provides superior clinical outcomes measured by pain, function, and that objective stair climb time. And it does that while crucially stabilizing the foot, preventing the adverse effects and discomfort that the lateral wedge alone often causes.
On the movement front, we saw the incredible leverage gained from personalized gait modification.
Small, personalized changes in how you walk, be it walking with a slightly wider step, or adjusting your foot progression angle to toe in or toe out, significantly reduce the knee adduction moment. And critically, these changes provide pain relief equivalent to or even better than chronic medication. Plus, that personalized foot progression angle modification showed tangible potential to slow actual cartilage breakdown over the course of a year. That means movement is medicine that actually modifies the disease process.
And finally, the accessibility of prediction is changing the game for clinicians everywhere.
By establishing that simple, accessible measures like walking speed, foot pain scores, and gender can predict who is most likely to be a successful biomechanical responder, we have eliminated the need for expensive lab testing. This allows clinicians to efficiently tailor treatment plans, moving toward genuinely evidence-based prescription.
So what does this all mean for the future of KOA management? Given that modern research has successfully combined passive devices and active movement adjustments, utilizing predictive factors that are clinically accessible, imagine a future where managing knee osteoarthritis is not about reaching for a pill bottle, but about receiving a precise, personalized, walking prescription.
A prescription that would be determined by a quick physical assessment, measuring your baseline gait speed and your pain scores, and then training you to walk at your optimal offloading step width or foot angle. We have moved from treating knee pain as an illness to recognizing it as a solvable engineering problem. The data is clear, and the necessary next step is integrating this personalized biomechanical blueprint into mainstream clinical practice across the globe.